Hi, this is Professor Meg Dean, and today we're going to be going over sensory for Nursing 102, and we're going to be talking about problems that affect the eyes and vision. It's very important that you kind of go back to the basics and review the anatomy and physiology of the eye. That'll really help you to be able to absorb the information in this particular unit to a deeper level. Just some particular things like understanding the lacrimal ducts and sac and the pupil and the sclera, just knowing some of that terminology is really going to help you. Also, in that second picture, you just see all the complexities of the muscles that are important in helping that eye to have full motion. And then the side view just kind of shows you the internal structures of the eye, and then that optic nerve that leads up into the cranium. All of that is very important as we talk about things like diabetic neuropathy and retinal detachment and things like that. So please make sure to go into your textbook and do just a quick review of anatomy and physiology of the eye. So for assessment and evaluation, as we know, everything starts with assessment. Some good things to consider as you're getting to know your client is, do they have any ocular history? Have they ever had any problems with vision in the past? You can certainly do some very simple things like get out the good old Snellen chart that looks at the eye's ability to recognize visual acuity items at a distance, and also where we get that 20/20 vision number. For smaller children, you may see, rather than having the letters, you may see pictures, like a pictorial view of the Snellen chart, because they don't know their letters, but they know what a boat is, or a house is, or a cat is, for example. There's also a Rosenbaum chart that can be used to look at the ability for eyes to recognize at near the face. You can do finger counts and hand motions. Those are very simple. Doesn't require any special equipment to just kind of do a quick assessment of a patient's just general ability to see. You want to just kind of look at the eyes. Do you see anything going on? Is there any inflammation, discharge? Are the sclera nice and white? Are the eyelids drooping or edematous? What about the pupils and pupillary response? Is your pupillary response nice and brisk and equal? Are the pupils symmetrical, or are they offset? It's a lot easier to do a pupillary exam when you're in a darkened room, and you will get more information on that when you take your advanced health assessment course. Make sure to practice on lots of people, because different people's eyes respond differently. So you want to definitely make sure to try to get a variety of people to practice that on. Also, kind of pay attention to where the patient is looking. Do they tend to be tracking you, following you, looking at you, or do they tend to be kind of gazed and looking off? That could be a clue that something's amiss. A couple of terminology pieces that might be helpful would be to know the term ptosis, which is the drooping of the eyelids, or nystagmus, which is that oscillating movement of the eyeball that we talked about in the ear and hearing presentation. So for diagnostic evaluation, there's lots and lots of diagnostics that can be done. With ophthalmoscopy, that's also called a fundoscopy, and that's a test that lets a doctor see the back of the eye, which is also referred to as the fundus. They can also see other structures in the eye as well. They use a little magnifying tool called an ophthalmoscope and a light source to see inside the eye. The slit lamp is a microscope with a very bright light used during an eye exam, and it gives the ophthalmologist or a doctor a very close look at the structures at the front of the eye and inside the eye, and it's very important in helping to determine the general health of the eye and detecting eye disease. Color vision testing to test if someone is colorblind. You've probably seen some of those little quizzes and things online, or maybe even on Facebook. The Ansler grid is a very nice early screening tool, a very simple one that you can use to sort of detect early changes that suggest macular degeneration. I've provided a link there for you if you want to do it on your own. It's pretty quick and easy and kind of fun. Certainly ultrasound can be used on the eyes. The optical coherence tomography specifically is a non-contact imaging technique that generates cross-sectional images of tissue with high resolution. It's when you can't get to a tissue like the back of the eye, this is a great technique to use. And you can't really get to the back of the eye to biopsy, but you can get a really good visual, and so that's what this does. The tonometry is a test to measure the pressure inside of the eyes, and that is to screen for glaucoma. It's also used to sort of evaluate how well the glaucoma treatment plans are working, so the effectiveness of those plans. Angiography is an exam by x-ray of the blood vessels in the eyes, important especially for those diabetic patients. And a perimetry test, I bet you've kind of all done this. That's where you, it measures the visual field, where you kind of look inside something. They oftentimes have this in the DMV and the flashing lights on the side. And that helps to evaluate one's ability to identify peripheral things in the peripheral vision. So that's perimetry testing. Let's see. For impaired vision, there are lots and lots of errors that can happen, and some of them are just based on the shape of the eyeball. So with these eyeball changes, you can have normal, which is great. That's emetropia. Myopia, those clients tend to be nearsighted, and you can see there's kind of like some elongation of the eyeball. It's not quite round. It's a little bit more like egg-shaped. Clients who are more farsighted or have hyperopia, and their eyeball is a little bit more compact, and so it's not quite as round. When a patient has an astigmatism, that is actually caused by distortion, caused by an irregularity of the cornea. So what about low vision and blindness? Low vision is defined as someone who has a best corrected visual acuity. So with glasses on, we've done everything we can, and still their vision is not 20/20. It's maybe 20/70 or 20/200, and that's evaluated using that Snellen chart. So these people do require some type of a device to get to some type of normal vision, although it's not corrected to full normal capacity as we would expect, like with that 20/20. Blindness is when we can only get, the best we can get despite intervention is 20 to 400, and they have no perception of light. Legal blindness is that best corrected vision that doesn't exceed 20/200 in the better eye, or the widest field of vision is 20 degrees or less. So they don't have much peripheral vision. It's a very narrow field of vision. And as you know, and we've probably talked about in class, impaired vision often comes with functional impairment. Difficulty in completing ADLs and working and those types of things. It can be quite debilitating. So assessment of low vision. Certainly we want to get a good history, any physical history, history of eye problems, familial history. Want to get a good examination, looking at as many variables as possible, using everything that we have available to us to assess. There are special charts that are available for use of those patients who do have low vision. For nurses specifically, what you should be really looking at is the patient, how does their vision or problems with vision affect their lives? And what can we do to help their lives be more manageable? So how are they coping? How are they adapting? What kind of support do they have in place? Are they having an emotional distress over this? Are they lacking in, physical hygiene or care? what can we do? What kind of social services or other support services could we link them to help them get to a higher level of functioning? So for management, we certainly want to support their coping strategies. We want to let them go through that grieving process of visual loss that is a significant loss in one's life, and then hopefully move on to that place of acceptance and management. So thinking about how we place items and describing where items are placed to help people be able to locate those items and use them effectively. When you are setting a tray of food in front of someone, you can say at 12 o'clock are your mashed potatoes. When you think of the face of a clock, that's universal. Everyone knows that 12 o'clock is right at the top. So 12 o'clock are where your potatoes are. 3 o'clock are your green beans. 6 o'clock is your dinner roll, etc. You get the idea. So a clock method for food trays can be very helpful to help promote independence with feeding. We certainly want to utilize communication strategies. Some folks will need to have Braille or other written materials provided in a way that they can translate. We want to collaborate with other health professionals like low vision specialists or occupational therapists or other community resources. And there are service animals too that can be very helpful to people who have any type of a sensory loss, and certainly vision is one of them. So what about medications? Oh, there's a lot of different eye medications. I know that you guys went over this in your medication administration in 101, but just to kind of recap before we get into like the nitty-gritties of the actual medications, remember that the ability of the eye to absorb medications is quite limited. Some of those barriers for absorption include the size of the conjunctival sac, the corneal membrane barriers, blood ocular barriers, and then things like those mechanical things like tearing and blinking and drainage that kind of flush those medications away. In some cases, an intraocular injection or a systemic medication might be needed to treat some eye structures or to provide high concentrations of medications. Most of the time, though, we're going to use like an eye ointment or an eye drop because they're least invasive, have the fewest side effects, and also they allow the patient to administer these medications on their own. Certainly some medications that you may come across would be like a topical anesthetic. So someone who has an eye irritation, there might be a topical anesthetic to ease some of that burning, that pain that an eye injury or a problem may cause. Mydriatics dilate, and cycloplegics paralyze the eye. Those are contraindicated with narrow angles or shallow anterior chambers, or patients who are on those MAOIs or tricyclic antidepressants, because they can cause CNS symptoms, increased blood pressure, and we especially see that in children and older adults. Another one would be anti-infective medications, antibiotics, antifungals, or antiviral drops or ointments to put in eyes for infectious processes. Certainly there are lots and lots of medications for glaucoma. Oftentimes those are given at bedtime. Sometimes they're also done in the morning. So you may, during your time as a nursing student, have the opportunity to administer some of these. But some of what these medications do is they help to increase the aqueous outflow and or decrease the aqueous production to sort of normalize the fluid pressures within the eyes. They can constrict the pupil and affect vision. And some of these do have some systemic effects. There are anti-inflammatory drugs like corticosteroid suspensions. Those can cause problems like glaucoma, cataracts, and increased risk of infections. So sometimes they'll alternate those with an NSAID to sort of maximize the benefit, minimize the risk. All right, let's talk about glaucoma. Glaucoma is a diagnosis that we do see relatively frequently. And when you think about glaucoma, I just want you to think of a pressure problem. So we have an increased intraocular pressure that's caused by congestion of the aqueous humor. And it can be caused by a number of different things. So the incidence does definitely increase with age, that's for sure. Um, and some of the risk factors are African American descent, cardiovascular disease, diabetes again, family history, migraine syndromes, myopia, older age, previous eye trauma, having a thin cornea, or prolonged use of those topical or systemic corticosteroid steroids. Clinical manifestations or signs and symptoms, the scary thing about glaucoma is it's called the silent thief because people don't even know they have it until they start to develop significant vision loss. Peripheral vision loss, they'll have maybe some blurring of the vision, they'll start seeing halos, have difficulty focusing, difficulty adjusting eyes to low lighting. Some patients may even have some aching or discomfort around the eyes or complain of headaches. So those are all signs and symptoms to be alert for when patients are complaining that it may be something with the eyes, glaucoma. So with this picture you have here, this comes directly out of your textbook, and there's really good information in your text about glaucoma. You have a normal outflow of the aqueous, but in glaucoma, we have an aqueous production or a drainage problem. And either way, we've got a balance issue. When our aqueous outflow is blocked, the pressure builds up in the eye, and that can cause irreversible mechanical or ischemic damage. So what about the different types of glaucoma? With wide angle, that's usually a bilateral. It can be either a normal tension, which has an optic nerve damage, or there could be ocular hypertension. Oftentimes those clients will complain of ocular pain or headache. Narrow angle, that's obstruction that results in increased ocular pressure. There's acute, which is very rapidly progressive. There are lots and lots of symptoms in your textbook's got a nice listing of those for you. Subacute, they kind of had just some transient blurring of vision, some occasional headaches. It's not anything that really grabs their attention because once they start worrying about it, it kind of goes away, but then it comes back. With chronic, that's where clients experience a significant loss of their visual field, and they typically do have also a pain and headache that goes along with that. This can be associated with other conditions, as we mentioned, like diabetes or cardiovascular disease. It can be primary or secondary, as it says they're congenital, so some poor children are born with this or have a propensity for it. And there are some testing there, the tonometry to assess the interocular pressure, ophthalmoscopy to inspect the optic nerve disc, and then the central visual field testing, as we've talked about earlier. So what are we going to do about it now that we know we're dealing with glaucoma? We want to prevent further optic nerve damage. That's the main thing, and we've got to maintain a good intraocular pressure. If we don't do that, we're going to have resulting damage. So we've got to do that pharmacologically. There's a whole list of medication there, miotics, beta blockers, alpha-2 agonists, et cetera, et cetera. So the list goes on. They may try a combination of things. And oftentimes these eye drops, they may be on multiple eye drops, 2 different ones. One drop, wait 5 minutes, and then take 2 drops of this other one. So they can be kind of complex, especially for older people who have visual acuity issues, to differentiate the different drops. There are also laser procedures, and in some cases, some clients may need surgery to treat this. So what about for us nurses? We need to assess for knowledge level and adherence to the plan of care. because if they're not able to understand the importance of their medications, specifically how to take their medications, when to take their medications, they're going to have increasing symptoms and a poor outcome. So education is important, that this is a chronic condition, so they're going to need to sort of get on board and stay on board. They need to understand their medications and what to watch for, side effects of those medications, etc. And also help people to just adjust to sort of this slow, gradual deterioration of vision and how they can cope with it and get around it and still lead a good life. All right, what about cataracts? This is an opacity or cloudiness of the lens. They're pretty easy to catch. This one in this picture here is a pretty significant cataract. We also see this with aging population. Other risk factors aside from aging would be diabetes. There we go again with the diabetes. Smoking, obesity, high blood pressure, previous eye injury or inflammation or previous eye surgeries, prolonged use of corticosteroid medications, excessive alcohol intake. And then here's one that we can all modify very easily: excessive exposure to sunlight. So a reason that wearing those sunglasses is so important. This is a leading cause of disability in the United States. It's preventable and it's treatable. There can be traumatic, congenital, or old age related causes of cataracts. So for your clinical manifestations, typically clients complain of sort of a clouded, blurred, or dim vision. And by that picture we just looked at, you can kind of imagine that that would be the case. They have an increasing difficulty with vision at night, sensitivity to light and glare. They need brighter light for reading and other activities. They may also see the halo effect around lights. They have frequent changes in eyeglasses or contact lens prescriptions. They may note a fading or yellowing of colors, and they may have double vision in a single eye. So certainly some diagnostic findings would be helpful. They can do that with the ophthalmoscope, the slit lamp, or inspection. Treatment for this is surgical management, and there are Surgery centers around town, and our Moline campus does a lot of quote-unquote eyes. It's a simple procedure, but not without risk. If they're able to manage life, we're just going to let them manage life. But if they need surgery to be able to have a more functional life, then certainly, again, surgery is a great option. It's done on an outpatient. It's a local anesthesia. So I think one of the scariest things for a patient is that needle coming towards you. It's quick, and patients are discharged quickly afterwards, usually a half hour to an hour after the procedure, and they are discharged. Complications are very rare, but obviously can be significant. They are working with the eye. There's a couple of different types of surgery listed there. The lens replacement is the one that I've seen most frequently used here in our local area. So what do we as nurses need to know? Many of you may have the opportunity to go to the Moline campus for some clinical opportunities in the second year. And if you do, you may get to sit in on an eye case, which would be very interesting. Certainly preoperative care is important, getting that IV placed and getting your history and a good baseline assessment and patient education, consent signed, all of the usual. Dilating eye drops and other medications may be ordered prior to going into the OR. Postoperative care is just simply vital signs and ensuring that their vision is being restored. They may have some continued kind of blurred vision that first month after surgery, and it will kind of gradually improve in their visual acuity. Patient education on what to do and what not to do. They definitely need written and verbal instructions, and ideally if they've got someone with them that can also listen to those instructions, because as you can imagine, anyone who has impaired vision may have difficulty in reading those instructions. Increase the size of the font on your discharge instructions as you print them. That's an easy thing to do. Some kind of Warning signs of something's going wrong and you need help immediately would be continuous flashing lights, redness, swelling, or pain. That could certainly indicate infection, drainage, or increasing pain that's not easily relieved by something over the counter, such as acetaminophen. There are some corneal dystrophies. Those are inherited problems. They're autosomal dominant. Most of them manifest by 20 years of age, and they have deposits in the corneal layers of the eye. The first one is keratoconus, and that one is the most common. We typically see that in women, and it presents with significantly blurred vision. The Fuchs endothelial dystrophy is where they have the endothelial cell layer of the cornea are just dying off. We also see this more commonly in women, but sometimes this one isn't detected until more midlife, closer to age 50. There's a lot of pain and discomfort that goes along with this one, and some swelling. So symptom management is important, and treatment would be a corneal transplant. Some retinal disorders, the main one would be retinal detachment. That is an emergency. There are also retinal vascular disorders. Macular degeneration is the one we're going to be spending the most time on today. So with retinal detachment, you guys, this is an emergency situation. There's a thin layer of tissue, that retina in the back of the eye, that pulls away from its normal position, and it separates the retinal cells from the layer of blood vessels that provides oxygen and nourishment. So that skin is, or that layer is going to quickly start to become ischemic and not regenerate. The longer the retinal detachment goes untreated, the greater risk of permanent vision loss in that affected eye. Risk factors for this are aging. We see this more commonly in people over the age of 50. If someone's had a previous retinal detachment, they're at much higher risk of developing this complication again. Family history, extreme nearsightedness, previous eye surgery such as cataract removal, previous serious eye injury, or other eye diseases or disorders can increase the risk of retinal detachment. Clinical manifestations that are classic would be like the sensation someone would have where like a shade was being pulled down, or coming across, like a curtain coming across their vision in one eye. They may also see bright flashing lights or a sudden onset of floating things or floaters in their vision. So what are we going to do? Well, we're going to assist with getting them into those diagnostic assessments with the provider as listed there, and we are just going to mainly be a support, provide education. These patients are going to need eye surgery. It can be done as an outpatient, so education is going to be the main role, education, monitoring. Complications of retinal detachment after surgery would be like increased interocular pressure, infection, etc. Those patients also should be like in a lying down in a prone position to kind of balance everything out for a little bit after surgery. Anyway, on to retinal vein or artery occlusions. That's where we have a loss of vision because we have either a vein or an artery that's occluded, so that eye is not being fed, essentially. This can be caused by the things that would cause a vascular occlusion in any other part of the body, like atherosclerosis, cardiovascular disease, venous stasis, hypertension, increased blood viscosity, and again, diabetes, glaucoma, and aging are all risk factors. These patients just report decreased visual acuity, and in some cases, a very sudden loss of vision. So it's almost like a stroke in your eye. And you may hear it discussed in those terms, like a stroke in your eye. Age-related macular degeneration. Your main risk is age. It accounts for 54% of all blindness in older adults. So it's the big boy. It's the one that causes the biggest problems. It can be dry or wet. Most commonly it's the dry, and that's a slow breakdown of layers in the retina. The wet type oftentimes has an abrupt onset. So what are we going to do about it? First of all, medical treatment is necessary. Photodynamic therapy will really slow the progression. That's a light sensitive dye that's injected into the vessels, and then a laser activates the dye and it shuts down the vessels without damaging the retina. The results then is to slow or stabilize the vision loss. The patient needs to avoid exposure to sunlight or bright light for about a week after treatment to avoid activation of the dye in the vessels near the surface of the skin. So for you, us, we as nurses, patient education, supportive care, safety promotion, and recommendations on just simple things we can do, like improve lighting, the use of magnification devices, and then certainly reaching out to those referrals and consultations to a vision center or occupational therapy or what other community resources may be available to improve function. Infectious and inflammatory disorders. Certainly you've heard of these, and maybe some of you even have experienced these. Dry eyes, kind of those dry, itchy, irritated eyes. Conjunctivitis, which is pink eye. We'll talk more about that specifically with our peds population. The bacterial is the one that's super contagious and needs an antibiotic eye drop, but it can also be fungal or parasitic. Allergic tends to be kind of watery or toxic. It can also be caused by just something getting in the eye. And viral conjunctivitis is also quite contagious. Uveitis or orbital cellulitis. Anytime we have cellulitis, that certainly also does need medical treatment. And many of you have taken care of patients with cellulitis of other body parts in the hospital. And it's not uncommon for patients with ocular cellulitis to also require hospitalization and IV antibiotic treatment. Systemic disease can certainly cause eye problems. Diabetic retinopathy. Diabetes is the leading cause of blindness in people ages 20 to 74 years. So that younger cohort of people, diabetic retinopathy is a problem. So we want to make sure that, we're doing good diabetic education, helping people to get their sugars within range so that they don't suffer those long-term, very serious consequences that are not reversible. Persons who have been diagnosed with HIV that then progress on to AIDS can also experience ophthalmic complications. And then certainly hypertension is called the silent killer for a reason. It's very deadly, but not only deadly as it also increases morbidity. And one of those problems can be with eye and vision. So what about safety measures and education? Patient education is so important always in nursing, but especially with someone with eye and vision disorders, they may not be able to read our instructions. So having that good connection with the patient and using the teach back method and ensuring that we're communicating with them in a way that they can understand and retain, and also pulling in family members is very important. We want to help people to prevent eye injuries, and that requires education. Using safety goggles is very important when doing like household repairs and things like that, when interacting with chemicals or anything that could splash into one's eyes. Think about safety strategies for people with low vision in the hospital and in the home setting to reduce the risk of falls. And then certainly we want to, again, reinforce education for patients who have had some type of an eye surgery or experienced trauma to reduce complications. Some patients, you need to wear a patch. They don't want to wear a patch, but it really can be very therapeutic in their plan of care. So what about trauma? Certainly prevention of injury is number one. We always want to prevent rather than have to treat. But your eyes are important. They are a very important sensory organ, and you only have two. So we want patients to really value their eyes and protect their eyes So prevention of injury is important. So education goes a long way, especially in occupational settings. We can provide patient and general public education as appropriate, depending on your type of work setting. Emergency treatment would be to flush chemical injuries. We never want to remove, and we don't want to encourage others to remove foreign objects. That should be done by a professional under very controlled environment, and protect using a metal shield or a paper cup. Now, if you have a trauma to one eye, there can be this sympathetic response of the body that actually causes blindness and also the uninjured eye. And so, again, it's really important that we reduce trauma and provide education where we can. If you have questions, don't hesitate to reach out to me. Email or in the Blackboard course. And as always, I look forward to your questions. Thank you.